I'm such a big fan of MDoc's work that, fun story, I actually asked Neka, the co-founder and CEO of MDoc, to give me access to the tool, because clearly I need it. And her response was no. So she's not here today. She will be here tomorrow and day after. And if you'd like to help me, I'd encourage you to go up to Neka and ask her why she draws the line at access at Bilal. Honestly, I would love it. It's a phenomenal tool. I got one laugh from Mark. Thanks, Mark. Next up, folks, I'm going to invite my panelists up to the stage. I'll introduce you one by one and then ask you to come up so that you can all get a round of applause because you are all incredible. So first up, we have Annie Hartley. Annie is a tenure-track assistant professor at Yale, visiting professor at EPFL. She developed Meditron, which is a fine-tuned large language model for the African clinical context, and also an online evaluation platform for large language models called Move, both of which I'm really hoping she talks to us more about today. So would you join me in welcoming Annie? And next, we have Vaish Menon. Vaish, much like myself, is a lapsed physician, but is currently working as a research fellow at the UK Centre for Excellence in Regulatory Science and Innovation for AI in Health. It's a real mouthful, so we shorten it to CERSI. It's the UK's national CERSI for AI in Health, and she's been supporting us at PATH on designing what I believe will be 3 of the world's first trials on evaluating large language models in clinical contexts, not just in Africa, but around the world. So join me in welcoming Vaish. And last but not least, Samuel Rotunda. Sam is the Chief Technology Officer at a phenomenal startup in Kigali, Rwanda called Digital Umaganda. And they focus on promoting the use of African voice technologies through dataset creation, model development, and field deployment of novel applications. Sam has been doing some incredible work on trying to figure out how you translate language which is captured in Kinyarwanda into English and back so that we can use large language models more effectively. And again, I'm sure he'll tell us more about his localization work today. I'm going to move over there now. So what we're going to start with, folks, is you've heard 2 phenomenal presentations, and really the purpose of those presentations was to give you a sense for how work is already being done across the sub-Saharan continent, which I think is world-leading. There are a few examples of similar self-care coaching technology deployed anywhere else in the world. There are few access to care tools like Jacaranda's prompts platform anywhere else in the world. And I think not only is it worth celebrating at a forum like this, but also worth reflecting on. So what I'm going to ask my panelists to do now is just to spend a couple minutes picking up on 1 or 2 things that our presenters shared and really helping us as an audience dive deeper into them. Annie, if I can start with you, and then if you could pass your microphone to Vaish, and I'll give Sam mine.
Okay, sure. So I think something that I liked from both of the presentations was definitely the concept of decentralization. This decentralization of access to information that can really empower the end user. And it's really important because this is openness, right? It's the whole theme of this conference as well. It's openness. But normally when we speak about open digital health, we're always speaking about open source or open access. So it's either open source for developers or open access to the end product, right? But there's very little open development. And to invite people and decentralize the development of these tools is actually something where I think there's a movement that's going towards that. And that's also what we're trying to do. So I had the opportunity actually to see MDoc in action in Nigeria. I just came back from Lagos, and really, really impressive platform. I was there actually with the International Committee for the Red Cross, and they had also an open development using FHIR in their tools, trying to get access to people who are really marginalized and affected by Boko Haram. And this power of decentralization, again, is just so important. But to get their voices back in to the system, and to not just co-design, but go beyond just having this middleman that is telling people how to design the tool, to really make platforms that allow people to, once it's designed, continue its development. We're doing that with a platform called The Move, which we'll speak about later. But I really appreciated the effort from MDoc as well to get the feedback from people and integrate it. from co-design, and we can go further, hopefully working with them soon to also bring that into co-development. So thank you.
Thanks, Annie. Vaj?
Thanks, Annie. So the point that I would like to pick up on is the two-way nature of how you are using AI not just for your patients, but also for your providers. I think the AI tools and products that I've come across or worked with are predominantly single user dependent, in the sense that for a medical practitioner to write a discharge summary or a radiology doctor to write an imaging report for the patient to be able to track a woman's fertility, they don't really go that one step beyond in talking about, oh, I've noticed something wrong, or I know that something's a little bit off. How can I interact with my patient or my doctor directly in order to bring about a change in good time? So I know, Jay, that you were mentioning that you not only provide help for a woman throughout her maternity journey, but you give that availability for her to ask questions. And the beauty of the AI there is that it has the ability to triage those questions and sort of bump up those red flag or higher risk queries to a human on the other end, most likely a healthcare professional. And I think it's that continuity loop that you also provide for your providers, whereby they can get feedback from the patient to provide that ongoing continuity of care that I really liked. And similarly, Hannah, with MDoc, in the UK at the moment, we're facing a huge backlog of waiting lists and a huge issue with trying to get to see your GP, especially for patients with chronic conditions like hypertension and diabetes. And I think a platform like MDoc is great because it provides reassurance to the patient that someone is watching my metrics on a dashboard, and also for the health coach to be able to come in good time to provide some care without any complications coming further down the line due to a delay. So yeah, I really like the two-user narrative that both of your platforms have, and I thought that was great for AI in the future.
Thank you. Yeah, I think I'll be using Proverbs. And I'll start with what Bilal said, no one left behind. And I'll talk on the work by Jacaranda. Where there is a will, there's a way. Because for most of us, it's been 15 years that we've moved to smartphones. But someone who is using a feature phone, they have to press the numbers, to reach the character. So it's not fun. And then every time they use it, they are charged. And then they must write 140 140 characters, and the response should be within that range. You can see that it's not what we are used to, but there is someone who needs it, and there is someone whose life will be changed because they've used that technology. And one thing that motivates me, and it's one of the reasons I do what I do, is the first person to use M-Pesa, or we call it Momo, mobile money, was my grandfather. Because it was designed to be a way to send money to people in the villages. But now it has caught on. Now it's a standard here in Kenya. Everything is M-Pesa. And I am seeing the work that they are doing to be that way. Even though it starts as an SMS, it's not the ideal way, but because it reaches to the one who needs it, it creates a real impact which reverberates and reaches out to many. And last year I was working on gender-based violence, rule-based USSD chatbot. And when I was doing it, I'm like, okay, this is not AI. Who's going to use it? And then last week, people have interacted with it over 2 million times. So I was like, okay, maybe I was wrong. And whenever we are thinking of technology, we really have to think, how do we build this inclusive when no one is left behind? Because the impact will always surprise you. Thank you.
Thanks, Sam. What I want to spend the next few minutes doing, and also while I do that, I'm going to look over to the organizers and say, I can't believe that no one has a question, because clearly people must have questions. So I'm going to blame the technology and say, can you make sure that I can see the new questions, or give me a laptop that shows me the new questions that are coming in? Thank you. So back to the panel. I want to spend a few minutes talking about localization. And really, this afternoon is mostly me trying to expose all the fun things that have happened over the last 6 months as I've been working with all of these brilliant people. So I'm going to put Sam on the spot and say, Sam, you spent 3 years trying to figure out how to effectively translate Kenya-Rwanda into English. And you did some brilliant benchmarking work against GPT-4. And then something very unexpected happened a few months ago when the Gates Foundation asked us to do it again. So could I ask you to share a little bit more about the localization work and then some of the hard lessons that we learned? And then Annie, as I mentioned before, you've done some great work trying to build large language models that are fine-tuned for the African clinical context. Can you tell us a little bit more about what it takes to build a Meditron, what you've learned on that journey? Who wants to go first? Sam, go on.
Yeah, I don't know if I should speak it out because
You should, Sam.
it's not fun for me. Yeah, the story is we've been, when we started, we are working on how can community health workers use LLMs to ask questions. So, and ask me anything chatbot. So we were working on how to do it in Kinyarwanda because they all speak Kinyarwanda, they don't speak English. So when we tested for GPT-4, that was actually in November last year, it scored 8%. And 8% was generous where people don't want to give it 0. It's gibberish. It didn't make any sense. So the strategy was, okay, let's use a machine translation. So we'll be translating the prompts into the Kinyarwanda question into English, and then we ask in English, and then we get back the response back from English, and then we translate back to Kinyarwanda. So we did that, and then to do that, we had to create our own data set. I think we have around 450,000 sentences that we had to create, and then now, translating health data is not easy. We had to look at the terms, so we had to create a lexicon of medical terms and everything. Then comes January, we test again GPT-4, it scored 86%. So, yeah, it's not fun for me because all the work I spent, basically, GPT-4 just beat me to the punch.
I'm telling you, don't be disheartened because we can't rely on GPT-4 to answer our medical questions. We need to make that open. This is the whole point of this conference, you know, and we need to include that kind of knowledge into our open models so that we can ensure that we can own the models, that we can control them. GPT-4, they can update their model at any time they like, and we don't have to know about it. We can't know about it. So all the trouble that we are going to validate tools, to make randomized control trials, they can just go poof. All that trouble to validate them, it gets updated randomly, and updated with what? Have they got maybe a new advertising campaign with a new pharmaceutical drug company? We need to be able to control our models, to localize them, to ensure that we can update them when we need to, and we need that kind of data in our open source tools. Sorry, and now I need to also answer your question.
No, Annie.
Answer your question.
Annie, you've done my job for me, so before you answer, and I think this is really speaking to the audience we have today, you've said exactly what I was going to, but much more articulate. We spent a long time in the digital health community trying to understand the purpose of open standards, how to justify that investment, because it looked expensive, right? We didn't understand why we were doing this, and everyone told us we needed an architecture, and we rejected that because it was easier to buy the widget and take the thing off the shelf. And I think this is a great example in the conversation we're having today. What Sam's story exposes, we can't rely on the widget. We can't rely on the private sector. So we do need to make the expensive investments. There is still an enormous role for the African language data set, but it's very easy to fall afoul and fall into the trap of seeing the article that tells you that GPT-4 now speaks Kinyarwanda. One, it's still crap on pretty much every other African language, surprisingly. And two, it does nothing for the open source development. and all of the work that folks in this community have invested so heavily in, but not for digital health at large, but rather that small little part of digital health that is applications of AI.
Okay, so I completely agree, and actually that's what Meditron was made for. So Meditron is our model, large language model for medicine. It's based on many kinds of different bases, so Llama 3, Llama 3.1, we have Gemma, we have a whole lot of other things. It's a suite of models in different sizes to suit different contexts. And we made it because of this need to own models, the need to contextualize them, to represent our setting in Africa. And as a doctor in South Africa, it's really important you know that the patient journey is different. It's really different. The WHO had a few years back still, but it was a statistic that over 80% of the African population first seeks care in some sort of traditional medicine before coming to the hospital. And even if they don't, if they do come to the hospital, you can be guaranteed that they'll be waiting in a very long queue. Our process of getting access to care is different. It needs to be represented. And we have to ensure that we can control that narrative in these models, which are narrative. So we wanted to make models that represented our setting. You can't just train it on PubMed and be happy. Because even PubMed, less than 3% of PubMed is actually representing the African context. So we have to go further. And we have to also not wait until it's perfect. We can't imagine that, oh, well, let's go and then collect all the data we need in Africa and get a great data set and then train the perfect model. It's not going to happen. And we'll wait forever to do it, and no one will give us funding to do it. So what can we do? So what we do is we accept that there's an imperfect model, and we make platforms to nudge it so that we can use the technology and use the generalizable utility of them. Some things in medicine are transferable across all countries, but nudge it while we are using it with evaluations and have that, what I said before, right, this kind of decentralization of development from the end user. So this decentralization is co-development from the user, from the patient themselves as well, if they want, to nudge it. When we are happy with a consensus of nudges, it gets to a point where it's a model that we can use. And that is the point of Meditron. And Meditron we were very happy with. It's the world's best performing open source large language model for medicine. But says who? Me? No, but says who? Says who? Me? Based on what? We need better evaluations. And I think that's the real problem here. Evaluations right now are multiple choice questions. They're unrealistic. No patient comes to you and says, I've got a chest pain and maybe A, B, C, or D, right? It's really important that we expose them to real world problems, real world questions, to ensure that they can be nudged in reality. Okay, I think that's my 2 minutes, right?
No,
okay.
I was just being told the questions are coming through, Annie. You keep going.
So last thing. You'll see later. I'm going to show you the move, maybe, if I have time. It tries to formalize this process, right? So this nudging process, where you can challenge a model in your setting, challenge it with questions that you know are important to your patients, and then see the answers and evaluate them, and then have a consensus of experts basically tell you where this model should go. MOVE stands for Massive, Open, Online Validation and Evaluation Platform. There we go. So what we're trying to do here is make sure that it is massive, which is really important, because generative AI models can answer any question from any prompt. Think of the permutations of things that can go right or wrong. So it needs to be massive. We need to test it in multiple different ways, from multiple different angles. It needs to be open, that's clear, but not open to everyone, right? We don't want some teenager in Helsinki nudging our model, right? We want experts. And so that's what we're trying to make sure, that we expose this to experts that are using the platform or affected by it. It's online, and it's a validation and evaluation platform. And I'll go through these very quickly so I don't monopolize this at all. So we want to make sure that it's locally owned through community alignment, getting experts in the community to align the models. Co-created through expert validation, which makes this transparent and accountable. If a community is, just like code, evaluating a model and pushing it in the right direction, we can have public oversight with public leaderboards so that people can know which model is best for them. It's great that GPT-4 was good in your environment, but you have to know the trade-off. How much better is it? It's continuous learning so that we can do this all the time, because evaluation is not a once-off. It has to be done continuously. These are learning systems, and they need a learning environment, and we hope to create that with the move. And the end result is, of course, an adaptive model that's relevant to our context. This is also an invitation, by the way. And if people want to sign up to the move, if you are an expert, a doctor that's in this room, and you'd like to sign up, please fill out the interest form, and we'll contact you as soon as I am finished traveling and that sort of stuff. All right, thanks.
Thanks, Annie. That was brilliant. I do want to dive a little bit deeper, though, into the Move platform is brilliant, but you've also started thinking about what questions do we need to ask? What are the axes that we are actually trying to evaluate? We saw a little bit from both Jai and Hannah about this, thinking about accuracy, contextual relevance. Vaish, I'm going to throw it over to you to start with. You've been working with us trying to design these 3 trials, thinking through what does it mean to figure out if an LLM is accurate. Can you give us a sense for what that means? And then I'm going to pass it over to Sam and Annie if you have any more reflections.
Yeah, that's a great question, Bilal, and it actually jumps right into the heart of what the University of Birmingham have been doing with PATH when we've been designing the 3 trials across Kenya, Rwanda, and Nigeria. I think for me, when I'm thinking about evaluating an LLM for a healthcare purpose, the take-home message is that this one-size-fits-all approach, it doesn't work. Even if you are working across 3 countries in the same continent. So I just want to take a little step back and just sort of ask the question as to why we need to evaluate LLMs in healthcare delivery. And that's because evaluation allows us to know whether a product or a tool is safe, if it's effective, and also culturally appropriate. And not just that, actually, I think it also allows us to know whether the technology that we are building, whether it truly serves the purpose for the people that it is designed for, whether you're a clinician working in an urban clinic in Kenya, or if you're a community health worker working in a rural Nigerian village. So there are some evaluation frameworks out there for evaluating LLMs in a healthcare setting. Some of you in the room may be familiar with MedPalm 2 or the framework related to MedPalm 2. It is primarily designed to work in a high-income context, looking at metrics like Bilal, you mentioned about accuracy and clinical reasoning. And I agree, I think those metrics are great. I think we definitely need to think about them. But what we've learned through these 3 trials is that when you are developing healthcare for a resource-constrained context, there are subtle nuances that these frameworks that are existing, they don't apply for some of them. For example, there are implementation challenges like language diversity and how to integrate the tool into the clinical workflow that these frameworks just don't account for. So when we've been developing these evaluation frameworks in Kenya and Rwanda and Nigeria, we've been thinking about other factors, more so human factors. How does the healthcare worker interact with the tool? Do they trust it? And, like I said, how does it integrate within this preset clinical workflow? So in Kenya, we've been working with a team called Penda Health and working with their clinicians in a primary care setting in an urban environment. And then in Nigeria and Rwanda, we've been working with community health workers in a more sort of rural environment, though they have a very broad spectrum of work. And whilst our 3 evaluation frameworks for all 3 share a common or similar focus in terms of safety and usability, the way that they differ is in terms of their implementation. So if I just used a few examples, our safety metric, for example, in Kenya, we are looking at, okay, is the advice that the LLM giving, is it safe because it complies with the norms of prescribing practice that you would see in an urban primary care setting? Whereas in Nigeria or Rwanda, we're looking at, okay, is it safe because the advice the LLM is giving is actionable for a community health worker in a rural environment? Similarly, if you think about our usability metric, in Kenya, we're trying to implement an LLM tool in an already pre-existing electronic medical record system, whereas in Nigeria, we are trying to implement an LLM tool in a low connectivity rural environment. So you have to think about the way, yes, you can have a framework like MedPalm2 in terms of accuracy and all of that, but the way that you use it needs to be specific to the context that you are working in. And I think that's the main thing that I want to say by those examples, is that you need to be able to be flexible to adapt whatever framework is set as a gold standard, and I use that in quotation marks, adapt it for the context that you're working in.
Amazing. I'm going to pass it over to Annie, and there's also a question from the audience I want to throw in, just because it seemed a bit spicy. The question was, the closed AI models only get more powerful, the cost of training grows exponentially. It's not wise to divert the limited resources that exist to open source wrappers, so why bother?
Okay, so that's a really, really important question. How much did it cost us to train Meditron, right? So first of all, are we reliant on open source models? At which point are we going to plateau in terms of their abilities? Are the abilities right now good enough? And so far, we've seen that the abilities right now are extremely useful. So do we have to future-proof something to imagine that it's like we're waiting for something in the future to be useful? The most important thing for us, right, I would say, how much did it cost us to train Meditron? Normally, we did continued pre-training. It's a very expensive process. It would have cost us about $5 million to make, and that is obviously inaccessible. But we can leverage the resources of academia, and we did it for nothing. And I think that's really important. Sustainable, and it can be. These are research tools, and we can make sure that they are available. There's a huge movement, not only just to open source a model, because what use is that? If you give someone an open source model, it's just it's a file with a whole lot of numbers in them. You give that to a doctor, what's the doctor going to do? We need to make sure that they are open access as well, and they are hosted, which costs about like $4,000 a month if you want to host a Llama 3 70 billion parameter model. These things are expensive. So how can you make sure that you become independent from the perceived low cost that you get from commercial sources? They can change that price anytime they want. And actually, it's been circulating on the news that, and other sources, that OpenAI, after they've gotten enough users, that they are planning to up their prices. By how much? What dependency are we putting on these systems? And why can't we host our own? Right now, when they are useful in their useful state, we don't have to have some bionic superhuman right now. They are already useful. So for me, I think open source, the control, the ownership, that we can own them ourselves, it's essential. They're useful now, and it's difficult to wait.
Thanks, Annie. I want to marry that with some back-of-a-napkin math at the Center for the Fourth Industrial Revolution. So Sam's partner in Rwanda did very early on in our collaboration with them, where this was, I think, about 2 price drops ago. So don't quote me and try and replicate the maths today. But trying to take the tool that had been built, where a community health worker could ask 1 question a day, we assumed 1 question a day on average across all 60,000 community health workers that the Rwandan government is planning to train and deploy, would have, I think, annually cost them like $6 million. So you've just heard Annie talk about what it costs to spin up a Meditron, and I'm telling you that to use a GPT-4 solution for, on average, 1 question a day per CHW would have cost the grand total of $6 million a year, right? Which government is going to pay this? And there's a great question, and I'm going to hand it to Sam to answer and also respond to the previous comments. The question was, costing the deploying and maintenance of LLM infrastructure is expensive. What are the mechanisms for transitioning this to government and sustainability? And Sam does a lot of work with the Ministry of Health, the Ministry of ICT, and also the Rwanda Biomedical Center. So I think he's got a fair bit of experience.
Yeah, there is the cost factor. So this solution might scale. So once they scale, it means you have to pay more because there is a need. But there's also a privacy concern. So most of the care done, at least in Africa, is done by either the community health workers or the nurses. So one thing that we are looking forward is how do we empower them to provide better healthcare by using LLMs. So that means that the LLM has to capture the information from the patient. So now, are you comfortable taking that information from a patient, private information, and giving it to a closed source where you don't know what they will do with the data? So which government is going to allow that as well? So that's another aspect. And then putting in a wrapper, yes, we are talking within the context of health, but there can be other contexts, such as agriculture, such as education, such as justice. So by making it open source, and if we crack the code from an open source community, it will open venues for the others. So it means with one model, you can deploy to other industries or sectors. So wrappers are good, but they can be limited. And over a long term, you'll find that you cannot control scale. Privacy will be an issue. And then expanding, you can only expand based on their direction and not your own need.
And I want to add, just there's also an important governance push in this as well. If we don't show that open source models can be as good as GPT-4, Meditron is performing as good, even on the move with real world questions, is performing as good or even better than GPT-4 in the specific domain of medicine. If we don't show that it can be useful, then there's no kind of push toward building the infrastructure that we need. And development will just lag behind because we create a dependence. And it's really, we have evolved beyond this dependency on foreign companies and stuff. We have the expertise in Africa. We need to develop it here. And so I really think that it's also a bad idea to rely on this sort of closed source technology because it also stifles our own innovation when we have so much potential to develop it ourselves anyway.
Okay, well, it seems like time has run away from me. So what I'm going to do is ask each of our panelists very quickly in 30 seconds, what is your one big reflection for the room? Many years of experience packaged up into one soundbite. What do you want everyone to leave here knowing? Vaish, Annie, Sam. Oh, Sam first, go on. No time to think.
Can you repeat the question?
What is the one reflection that you have that you want everyone to leave this room knowing and understanding?
So it takes a village to raise a child. And it will take all of us to bring forth this technology. And yeah, okay, can I expand? Okay, so.
Very briefly.
Yes, we have different people within the ecosystem. We have the medical practitioners, we have the patients, we have the policymakers, we have those building the technology. And unless we all collaborate and unless we are all ready, it will not work. And on that, even, for example, international organizations, the WHO have a lot of content material in health, but the beneficiaries, they don't speak necessarily English. So how can they make it available in other languages? So we all have, one way or another, a role to contribute. Thank you.
Thanks, Sam. Vaish?
So I think my main message is going to go back to what I said previously about evaluation frameworks, and we shouldn't just assume that because a framework works in one context that it is going to be okay to take it elsewhere. We need to refrain from this one-size-fits-all. Thanks, Bilal. I was wondering when you were going to put my meme up. But we shouldn't just assume that this one-size-fits-all approach for a framework is going to fit into every context that you're working in. We've spoken a lot about accuracy, and I just think, what's the point of having an LLM that rates really highly on accuracy if the user at the end of the day doesn't trust it, or the advice that it provides is not relevant to their local context, or it's not actionable within the realms of their confinement. So yeah, I would just say that if we want to build technologies that are going to address the local challenges and needs, we need to think about the specificities within the situation that we're working in.
Yeah, I think it's time for us to not think that there's so many barriers to owning this technology. It's not out of our reach, it's open, and we can actually decentralize the ownership of this technology to the end users through appropriate evaluation. And this decentralization can make local ownership, can make co-design, co-development, and it can make sure that we represent our settings and our patients and ensure that it's closer to what we actually want to use and what the patients deserve.
Thank you very much. Ladies and gentlemen, Annie Weissenstein.